Each year, more than 1 million people globally are diagnosed with NSCLC. Despite treatment advancements in other types of lung cancer, progress for ROS1-positive NSCLC has been limited and unmet needs remain. Enter AnHeart Therapeutics. We're a global biopharmaceutical company investigating novel precision therapies to improve the lives of people living with cancer. Visit our booth at the 2024 ASCO annual meeting to see how AnHeart is leading the next era of research for people living with ROS1-positive NSCLC.
Hello, I'm Dr. Vamsi Velcheti, your guest host of the ASCO Daily News Podcast today. I'm a professor of medicine and director of thoracic medical oncology at the Perlmutter Cancer Center at NYU Langone Health. On today's episode, we'll be discussing recent updates on the management of early-stage non-small cell lung cancer, including the optimization of neoadjuvant and adjuvant treatment options for our patients, and the evolving role of surgery in the era of targeted therapy and immuno-oncology in lung cancer. Today, I'm delighted to be joined by two renowned experts in the space, Dr. Sandip Patel and Dr. Mike Zervos. Dr. Patel is a professor of medicine and medical oncologist specializing in lung cancer at UCSD. Dr. Mike Zervos is a clinical chief of the Division of Robotic Thoracic Surgery and director of general thoracic surgery at NYU Langone. Our full disclosures are available in the transcript of this episode, and disclosures relating to all episodes of the podcast are available at asco.org/DNPOD. Dr. Patel and Dr. Zervos, it's a great honor to have you on the podcast today. Welcome on board.
Great to be joining you.
Let's get started with Dr. Patel. As you know, over the last decade, we've had dramatic advances in systemic therapy options for patients with metastatic non-small cell lung cancer, both in the realm of targeted therapy and immunotherapy. These have significantly improved outcomes for our patients with metastatic lung cancer patients. And what's exciting is more recently, we've seen incorporation of these agents, both targeted therapies and immunotherapies, in early stage non-small cell lung cancer. Dr. Patel, can you tell our listeners about these exciting recent advances, and why do you think it's so important to incorporate these personalized systemic therapy options for our early stage patients?
I think it's a great point and a great question. And so I think one thing to understand is that non-small cell lung cancer is actually multiple diseases. We give it one name based on how it looks under the microscope, but the vast majority of our advances to improve outcomes for patients have come from our ability to understand specific subgroups. And many of our therapies have had activity in the advanced setting for patients with metastatic or more widespread disease, which naturally led to the thought that could we utilize these therapies in earlier stage disease and potentially increase the rate of cure for many of the patients, lung cancer being the most common cancer killer worldwide. And so to your point, trying to understand how to best treat a patient really involves personalized medicine, typically driven by understanding the genomic profile of their tumor and to the genes that have graduated from being tested for in the metastatic setting and now in the localized setting are EGFR and ALK. And these in particular are mutations that confer sensitivity to small molecule inhibitors, EGFR with osimertinib, ALK in the localized setting with alectinib based on the data that we've seen. And so one of the areas that's been particularly exciting is our ability to maximize a patient's chance for durable remissions by integrating these therapies after surgery, after chemotherapy when appropriate, and continuing generally for a finite amount of time, 2 to 3 years, depending on the agent and study we're discussing for these patients. Additionally, immunotherapy, which has revolutionized our treatment of patients with metastatic disease, may be particularly well suited for the localized setting of non-small cell lung cancer as well.
Excellent point, Sandip. You're absolutely right. I think in metastatic setting, we've all come to kind of accept molecular testing, sequencing, biomarker profiling as a standard. But that unfortunately hasn't quite yet percolated into the early stage setting. Can you talk about some of the challenges that we face as we kind of have these therapeutic options available now for more early stage patients?
So I think there are 3 flavors of localized therapy in non-small cell lung cancer. One is advanced unresectable stage 3, for which the approach is often concurrent chemoradiation followed by some form of consolidative therapy. We're about to hear the results of LAURA, which is the study looking at EGFR mutated non-small cell lung cancer. For other patients, historically, the treatment has been durvalumab, an anti-PD-L1 directed immunotherapy. The other 2 are operative treatment of localized cancer, adjuvant treatment after surgery, or neoadjuvant or perioperative, in which the chemoimmunotherapy begins before surgery. And testing depends on the setting. So for the stage 3 patient who's likely getting concurrent chemoradiation, they may have a very small amount of tissue. And so often these are done by pulmonary EBUS biopsies, and that's how we pathologically confirm that advanced stage 3B. And so there may not be a lot of tissue for molecular testing. In fact, if you look at the Pacific analysis, just looking at PDL1, which is just an IHC off a single slide, a third of patients weren't able to even get a PDL1, let alone a genomic result. And so I think that's one of the areas of LoRa that's going to be particularly interesting to see as we try to implement it into our practice after seeing the full data. I think in the adjuvant setting, we're lucky because our surgeons, Dr. Mike Zervos here, will get us a large amount of tissue in the surgical resection specimen. So we tend to get enough tissue to do genomics. And while they're on their chemotherapy, there tends to be time to wait for their genomic result. But where this gets really complicated is in the neoadjuvant or perioperative setting, where time is everything, right? The most important thing we can do for a patient in the localized space is get them to the operating room, get them started on radiation, their curative local modality. And that's where we have a time pressure, but also a sample pressure, right? Because that's a diagnostic biopsy. It's a very small piece of tissue initially. There are multiple stains that have to be identified as lung cancer as opposed to another tumor. And so that's an area that I think we're going to need additional approaches, given that cell-free DNA tends to have lower yield at lower stage disease and giving us a result.
How do you deal with this issue in San Diego? Like the challenges, now we have like a lot of trials. We'll talk about those neoadjuvant immunotherapy trials, but we know that immunotherapy may not be as effective in all patients, especially if they have EGFR, ALK, or some of these non-smoker oncogene-driven tumors. So we don't want to be giving patients treatments that may not necessarily be effective in the neoadjuvant space, especially when there's a time crunch and we want to get them to surgery and all the complications that come with like giving them targeted therapy post-IO with potential risk for adverse events.
Absolutely. It's a great point. And so I think the multidisciplinary team approach is key. And, having a close relationship with the interventional pulmonary docs, interventional radiology, surgery, radiation oncology to ensure that we get the best treatment for our patients. With the molecularly guided therapies, they're currently more in the adjuvant setting in terms of actually treating. But as you mentioned, when we're making a decision around neoadjuvant or perioperative chemo-IO, it's actually the absence, right, of EGFR and ALK that we're looking for because our intervention at the current time is to give chemoimmunotherapy. And so there are, going back to the future, right, we used to do single gene EGFR, right, in 24 hours. It was insufficient for a metastatic panel, but it often required, 5 slides of tissue input. ALK can be done by IHC. And so some of these oldie but goodie pathologic techniques, and that pathologist, if I haven't emphasized, understanding what we're trying to do in a different context is so key because they're the ones who really hold the result. And in the neoadjuvant and perioperative setting, which many of us favor, especially for stage 3, especially stage 3A, stage 2B disease, understanding how we can get that result so that we can get the patient to the operating room in an expeditious way is so important. There's a time pressure that we always had in the metastatic setting, but I think we feel much more acutely in the neoadjuvant and perioperative setting, in my opinion.
Fascinating insights, Dr. Patel. So turning to Dr. Zervos, from a surgical perspective, there's been an evolution in terms of minimally invasive techniques, robotic approaches, and we really had like enhanced recovery protocols, significantly improving outcomes in our patients post-surgery. So how do you see the role of surgery evolving, especially with the increasing complexity and efficacy of these systemic therapies? How do you envision the role of surgery in managing these early stage patients? And what are the key considerations for surgeons in this new era?
Thanks, Fancy. Thanks, Sandip. Thank you for having me on the podcast. Obviously, it's an honor to be a part of such a high-level discussion. I have to say, from a surgeon's perspective, we often listen to you guys talk and realize that there's been a lot of change in this landscape. And I think the thing that I've kind of seen is that the paradigm here has also changed. If we were having this discussion 10 years ago, a lot of the patients that I'm operating on now, I would not be operating on. It really has been amazing. And I think probably the thing that stands out to me the most is how all of this has really changed with neoadjuvant chemotherapy checkpoint inhibition. I think for us as surgeons, that's really been the key. And whether it's Checkmate 816 or whatever you're following, Pacific, the data, supports this. And I think what we're seeing is that we're able to do the surgery, we're able to do it safely. I think that the resectability rates are definitely high up there in the 90% range. And what we're seeing is pretty significant pathologic responses, which I think is really amazing to me. We're also seeing that this is now shifted over to the oligometastatic realm. And a lot of those patients are also being treated similarly and then getting surgery, which is something that we would not have even thought of ever. When you look at the trials, I think a lot of the surgery to this point has been done more traditionally. There's a specific reason why that happens, specifically more through thoracotomy, less with VATS and less with robotic. Sandip, I think you guys have a pretty robust robotic program out at UCSD, so I'm sure you're pretty used to seeing that. As you guys have become so much more sophisticated with the treatments, we've also had to modify what we do operatively to be able to step up to the plate and accept that challenge. But what we are seeing is, yes, these treatments work, but the surgeries are slightly more complicated. And when I say slightly, I'm minimizing that a little bit. And what's complicated about it is that the treatment effect is that the chemo immune check inhibition actually has a significant response to the antigen, the tumor antigen, which is the tumor. So it's going to necrose it, it's going to fibrose it, and wherever there is tumor, that response on the surgical baseline level is going to be significant. In other words, there are going to be lymph nodes that are stuck to the pulmonary artery, lymph nodes that are stuck to the airway, and we've had to modify our approaches to be able to do that. Now, fortunately, we've been able to innovate and use the existing technology to our advantage. Personally, I think robotics is the way that we've progressed with all this, and we're doing all of these surgeries robotically, mainly because I think it's allowing us not only to visualize things better, but to have a sort of better understanding of what we're looking at. And for that matter, we're able to do a better lymph node dissection, which is usually the key with a lot of these more complicated surgeries, and then really venturing out to doing more complicated things like controlling the pulmonary artery. How do we address all this without having significant complications or injuries during the surgery, getting these patients through after they've successfully have completed their neoadjuvant treatment, getting them to surgery, doing the surgery successful, and hopefully with minimal to no morbidity, because at the end, they may be going on to further adjuvant treatment. So, all of those things I think are super, super important. I think although it's really changed the landscape of how we think of things, it's really made it slightly more complicated, but we're really up for the challenge. So I'm definitely excited about all of this.
For some reason, like medical oncologists, we only get fixated on the drugs and how much better we're doing. But we don't really talk much about like the advances in surgery and the advances in terms of outcomes. Like post-op mortality has gone down significantly, and especially in larger tertiary care centers. So our way of thinking traditionally, the whole intergroup trials, the whole paradigm of, immunity being bad and like bad outcomes overall, I think, we can't really judge and decide on current treatment standards based on surgical standards from like decades ago. And I think that's really important to recognize.
All of this stuff has really changed over the past 10 years. And really, I think the technology has helped us evolve over time. And as the science has evolved for you with the clinical trials, the technology has evolved for us to be able to compensate for that and to be able to deal with that. But, I think the data is real for this. Personally, what I'm seeing is the data is better for this than what it was for the old intergroup trials. We're able to do the surgery in a better, more efficient way, in a safer way. The majority of these surgeries for this are not going to be pneumonectomies. They're going to mostly be lobectomies. I think that makes sense. I think for the surgeons or who might be listening, doesn't really matter how you're actually doing these operations. I think if you don't have a very extensive, minimally invasive or robotic experience, doing the surgeries open is fine, as long as you're doing the surgery safely and doing it to the standard that you might expect with complete lymph node clearance, mediastinal lymph node clearance, intrapulmonary lymph node clearance. And really, I think that's where we have to sort of drive home the point, really less about the actual approach, even though our bias is to do it robotically because we feel it's less morbidity for the patient. The patients will recover faster from the treatment and then be able to go on to next phase treatments.
In some of the perioperative trials, the neoadjuvant trials, there has been some concerns raised about 20% of patients not being able to make it to surgery after induction chemoimmunotherapy. Can you comment on that? And why do you think that's the case? Sandip?
Oh, I think there are multiple reasons. If you look, about half may be due to progression of disease, right? Which they may not have been great operative candidates to begin with, right? Because they would have had early progression afterwards. And some small minority in a given study, maybe 1% to 2%, it's immune-related adverse event that's severe. And so it's something we definitely have to think about. The flip side of that coin, only about 2 in 3 patients get adjuvant therapy, whether it be chemotherapy, immunotherapy, or targeted therapy. And so our goal is to deliver a full multimodal package where, of course, the local therapy is hugely important, but also many of these other molecular or immunologically guided agents have a substantial impact. And I do think the point around neoadjuvant and perioperative is well taken. I think it's a discussion we have to have with our patients. I think in particular, when you look at higher stage disease, like stage 3A, for example, the risk-benefit calculus of giving therapy up front, given the really phenomenal outcomes we've seen, really frankly, starting with Nadim, Checkmate A16, now moving on into studies like Keynote 671, Aegean, it really opens your eyes in stage 3. Now, for someone who's stage 1, right, stage 1B, is this a patient who is eager to get a tumor out? Is there as much of an impact when we give neoadjuvant therapy, especially if they're not going to respond and they may progress from stage 1 and beyond? I think that's a reasonable concern. And how to handle stage 2, I think it's very, very heterogeneous. I think kind of 2 points that kind of happen as you give neoadjuvant therapy, especially chemo IO, that I think it's worth for folks to understand. And this goes to Mike's earlier point. One is this concept: if you do get a scan during their neoadjuvant chemoimmunotherapy, there is a chance of nodal flare, where the lymph nodes actually look worse and it looks like their disease is progressing. Their primary tumor may be smaller or maybe the same. But when you actually go to the OR, those lymph nodes are chock full of immune cells. There's actually no cancer in those lymph nodes. And so that's a bit of a red herring to watch out for. And so I think as we're learning together how to deliver these therapies, because the curative intent modality is, in my opinion, is the local modality. It's what Mike does in the OR, or my colleagues here do in the OR. My goal is to maximize the chance of that, but really maximize the long-term cure rates. And we know, even as well as a surgery can go, if only 2 in 3 patients are going to get adjuvant therapy, then 1 in 10, of which half of those, or 1 in 20, not getting to surgery, and that's, of course, a big problem, is a concern. I think better selecting for those patients and thinking about how to make these choices is going to be hugely important as we go over, because in a clinical trial, it's a very selected population. The real world use of these treatments is very different. And I think one other cautionary tale is that we don't have an approval for the use of neoadjuvant or perioperative therapy for conversion therapy, meaning someone who's quote unquote borderline resectable, right? At the time at which you meet the patient, they would be resectable at that moment. That's where our best evidence is at the current time for neoadjuvant or perioperative approaches.
The other major issue is like the optimal sequencing of immune checkpoint. So obviously at this point, we have like multiple different trial readouts, and there are some options that patients can have just neoadjuvant without any adjuvant. Still, we haven't figured out how to kind of de-escalate post-surgery immunotherapy interventions. And I think, there's a lot of work that needs to be done. You're certainly involved in some of those exciting clinical trials. But what do you do right now in your clinical practice when you have patients who have, let's say, a complete pathologic response to neoadjuvant immunotherapy? What is the discussion you have with your patients at that point? Do they need more immunotherapy, or are you ready to de-escalate?
I think MRD-based technologies, so cell-free DNA-based technologies, will hopefully help us guide this. Right now, we're flying blind along 2 axes. So one is we don't actually know the contribution of the post-operative component for a patient who gets preoperative chemo. And so this is actually going to be an ongoing discussion. And for a patient with PATH-CR, we know the outcomes are really quite good based on CheckMate A16, which is a pure neoadjuvant or front-end only approach. Where I actually struggle is for a patient who maybe has 50% tumor killing. If a patient only has 10% tumor killing, right now, the analogy I make in clinic is it's a traffic light. So it's a green light if you get a PATH-CR. It's a yellow light if you have that anywhere from 20 to 70% residual viable tumor. And then anything greater than that, you didn't get that much with chemo IO. And you're wondering, giving more chemo or IO, what would actually that do, right? It's a bit of a red light. And I'm curious, we don't have any data, but my guess would be the benefit of the post-operative IO is mainly for those patients in kind of that yellow light zone, who maybe a couple more cycles will get them an even more durable response. But I am curious if we're going to start relying more on MRD-based technologies to define treatment duration. But I think it's a very complicated problem. I think folks want to balance toxicity, both medical and financial, with delivering a curative intent therapy. And I am curious if this may be, as we're looking at some of the data, some of the reasons around preferring a perioperative approach where you scale it back as opposed to a neoadjuvant only approach where there's not a clean way to kind of add on therapy, if you think that makes sense. But it's probably the most complicated discussions we have in clinic. And the discussion around a non-PATH-CR, and frankly, even the tumor board discussions around localized non-small cell lung cancer have gone very complex for the benefit of our patients, but we just don't have clean data to say this is the right path.
And I think the need for really true multidisciplinary approach and discussing these patients in the tumor board has never been more significant. At larger academic centers, we have the luxury of actually kind of having all the expertise on hand. But how do we scale this approach to the broader community is a big challenge, I think, especially in early stage patients. Of course, not everyone can travel to Dr. Zervos or you for care at large tertiary cancer centers. So I think there needs to be a lot of effort in terms of trying to educate community surgeons, community oncologists on managing these patients. I think it's going to be a challenge.
If I could just add one thing here, I completely agree with everything that's been said. I think the challenge is knowing beforehand. Could you predict which patient's going to have a complete response? And for that matter, say, okay, well, this one has a complete response. Do we necessarily need to operate on this patient? And that's really the big question that I have. I personally have seen some complete response, but what I'm mostly seeing is major pathologic response, not necessarily CR. But we are seeing more and more CR, I do have to say. The question is, how are you going to predict that? Is looking for minimal residual disease after treatment going to be the way to do that? If you guys could speak to that, I think that is just tremendously interesting.
I think, as Sandip said, MRD is looking very promising, but I just want to caution that it's not ready for prime time clinical decision making yet. I'm really excited about MRD approaches to kind of like select patients for de-escalation, escalation, and surgery, no surgery. I mean, I think we probably are not quite there yet in terms of surgery, no surgery decision, especially for patients who have early stage cancer. We're talking about curative intent treatment here, and surgery is a curative treatment. And not going to surgery is going to be a heavy lift. And I don't think we're anywhere close to that yet. I'm glad we're having those discussions, but I think maybe too hard at this point based on the available technologies to kind of predict CR. We're not there.
Can I ask you guys what your thought process is for evaluating the patients, or when you're actually thinking about, hey, this patient's actually had a good response, I'm going to ask the surgeons to come and take a look at this. What imaging studies are you actually using? Are you just using strictly CT, or are you looking for the PET? Should we also be thinking about restaging a lot of these patients? Is obviously one of the things that I hate as a surgeon is getting into the operating room only to find out that I have multiple nodal stations that are positive, which really, in my opinion, that's sort of a red flag. And for me, if I have that, I'm thinking more along the lines of not completing that surgery because I'm concerned about not being able to provide an R0 resection. or even having surgical staple lines within proximity of cancer, which is not going to be good. It's going to be fraught with complication. So a lot of the things that we as surgeons struggle with has to do with this. Personally, I like to evaluate the patients with an IV intravenous CT scan to get a better idea of the nodal involvement, proximity to major blood vessels, and potentially even PET scan. And though I think, in this day and age, a lot of the patients will get the PET beforehand, not necessarily get it approved afterwards. So that's a challenge. And then the one thing I do have to say that I've definitely have found helpful is if there's any question, doing the restaging or the re-EBIS at that point to be particularly helpful.
Yeah, I would concur that having that pathologic nodal assessment is probably one of the most important things we can do for our patients. For a patient with multinodal positive disease, the honest truth is at our tumor board, that patient is probably going to get definitive chemoradiation followed by either immunotherapy or potentially soon, if they have an EGFR mutation, osimertinib. For those patients who are clean in the mediastinum and then potentially have nodal flare, oftentimes what our surgeons will do as the first stage of the operation, they'll actually have the EBUS repeated during that same anesthesia session and then go straight into surgery. And so far, the vast majority of those patients have proceeded to go to surgery because all we found are immune cells in those lymph nodes. So I think it's a great point that it's really the pathologic staging that's driving this, and having a close relationship to our pathologist is key. But I think one point that I think we all could agree on is the way that we're going to find more of these patients to help and cure with these therapies is through improved utilization of low-dose CT screening in the appropriate population in primary care. And so getting buy-in from our primary care doctors so that they can do the appropriate low-dose CT screening along with smoking cessation and find these patients so that we can offer them these therapies, I think is something that we really as a community need to advocate on. Because a lot of what we do with next generation therapies, at least on the medical oncology side, is kind of preaching to the choir. But getting the buy-in so we can find more of these cases at stage 1, 2, or 3, as opposed to stage 4, I think is one of the ways we can really make a positive impact for our patients.
I just want to go back to Mike's point about the nodal. So especially for those like multi-nodal, multi-station disease, right? I mean, that's, in my opinion, those anatomic unresectability is kind of a moving target, especially with improving systemic therapy options. The utilization for chemoradiation has actually gone down. So I think that's a different clinical subgroup that we need to kind of think differently in terms of how we do the next iteration or generation of clinical trials. Are they really benefiting from chemo IO induction? And maybe we can get a subset of those patients in surgery. I mean, I personally think surgery is probably a more optimal, higher yield to potentially cure these patients versus chemoradiation. But I think how do we identify those patients is a big challenge. And maybe we should kind of do a sequential approach, induction chemo IO with the intent to kind of restage them for surgery. And if they don't, they go to chemo consolidation radiation, I guess. So I think we need to rethink our approach to those anatomically unresectable stage 3s. But I think it's fascinating that we're having these discussions. We come to accept chemoradiation as a gold standard, but now we're kind of challenging those assumptions. And I think that, that means we're really doing well in terms of systemic therapy options for our patients to drive increased cures for these patients.
I think from my perspective as a surgeon, if I'm looking at a CAT scan and trying to evaluate whether a patient is resectable or not, one of the things that I'm looking for is extent of the tumor, proximity to mediastinal invasion, lymph node status. But if that particular patient is resectable up front, then usually that patient that receives induction chemo checkpoint inhibition is going to be resectable afterwards. The ones that are harder are the ones that are borderline resectable up front or not resectable. And then you're trying to figure out on the back end whether you can actually do the surgery. Fortunately, we're not really taking many patients to the operating room under those circumstances to find that they're not resectable. Having said that, I did have one of those cases recently where I got in there and there was multiple lymph node stations that were positive. And I have to say that the CT really underestimated the extent of disease that I saw in the operating room. So there are some challenges surrounding all of these things.
No, absolutely. And I think for those patients, if upfront identification by EBA showed multinodal involvement, we've had excellent outcomes with working with radiation oncologists, using modern radiotherapy techniques with concurrent chemoradiation followed by either immunotherapy, more targeted therapy, at least it looks like soon. So I think finding the right path for the patient is so key. And I think getting that mediastinal pathologic assessment as opposed to just guessing based on what the PET CT looks like is so important. If you look at some of the series, 8 to 10% of patients will get a false positive PET on their mediastinal lymph nodes due to, coccidiomycosis or sarcoidosis or various other things. And the flip side is there's a false negative rate as well. I think Mike summarized that as well. And so I think imaging is helpful, but for me, imaging is really just pointing the target at where we need to get pathologic sampling, most commonly by EBUS, and getting our interventional pulmonary colleagues to help us do that, I think is so important because we have really nice therapeutic options, whether it's curative intent surgery, curative intent chemoradiation, where we as medical oncologists can really contribute to that curative intent local therapy, in my opinion.
Thank you so much, Sandip and Mike. It's been an amazing, insightful discussions, really dynamic interplay between systemic therapy and surgical innovations, really exciting times for our patients and for us. Thank you so much for sharing your expertise and sharing your insights with us today on the ASCO Daily News Podcast. I want to also thank our listeners today for your time. If you value the insights you hear today, please take a moment to rate, review, and subscribe to the podcast wherever you get your podcast. Thank you so much.
Thank you.
Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.